So what we found is that you actually can use these predictive models to have a way to separate people who do acquire HIV from those who don't with pretty good discrimination. And discrimination is the metric we use to identify the best model in terms of prediction. And so the discrimination for the best model was 0.82, and this is talking about the area under the curve in terms of a receiver operating curve. And this is a statistic that helps you figure out how good the model is at distinguishing people who acquire HIV versus those who don't. And this is something that actually compares pretty well to other predictive models that have been used in other areas of medicine. So we think it may have good clinical utility. Some limitations include this algorithm may have some false positives, it may have some false negatives. The predictive accuracy is by no means perfect. So in terms of implementing this in a care setting, you would want to ideally use the algorithm to identify which patients within a larger population may be candidates for PrEP, and then you could alert clinicians to have more comprehensive risk assessments in terms of an in-person process. But no algorithm is perfect, so you'd always want to couch this in terms of a first stage screening test, and then clinicians could get into more of a detailed risk assessment with patients. Also, the limitations include the use of electronic health records data. In terms of behavioral risk for things like HIV infection, some of those are not captured in electronic health records. For example, you may not have documentation in structured EHR data of someone's relationships or the HIV status of their sexual partners. So again, this is a great way to screen a large population very efficiently using a computerized automated algorithm to identify subpopulations that may be candidates for PrEP for more intensive screening by a clinician, but it's never going to tell you exactly who should or should not be getting PrEP.